This is Mike Cheese. I'm the chair of the First Committee, and I'm here at SCCT 2014 in beautiful San Diego, California. And I'm joined by Dr. Frank Rubicki from the Applied Imaging Science Laboratory at Brigham and Women's Hospital. Thanks for joining us today.
Thanks for having me, and appreciate the opportunity to speak with you.
Dr. Rubicki, beyond looking at the coronary anatomy, how can we use cardiac CT to look at the hemodynamic significance of lesions?
I think that there are several ways to evaluate hemodynamically significant lesions. The first method that is now becoming more and more popular and more validated is CT perfusion. And so perfusion imaging gives you the opportunity to look at the myocardium with a second contrast injection and to actually see defects in the myocardium so that CT can be used in a way that other modalities will traditionally look for perfusion deficits, of those other modalities being something like cardiac MR or nuclear cardiology. And so CT can be used at the myocardial level to look for perfusion defects with stress agents. And there is a large amount of data now that's come out, including the Core 320 trial that I was part of. And those data are convincing that CT can show abnormalities in the myocardium that can then be used in conjunction with CT angiography to show lesions that have a hemodynamic significance. In Core 320, the reference standard was a combination of catheterization and nuclear imaging. On the other fronts, because there's other ways to do this, there is opportunities within the CT angiogram to use data that we traditionally don't use or we traditionally throw away. That is, if you read a CT angiogram, you traditionally will walk through the vessel in 2 dimensions, and you will, make multiplanar reformatted images and determine what the stenosis is. There's a lot of information that is not being used that can be used to actually access hemodynamic significance. The first part of that is the entire 3D geometry, which you typically don't look at. It's, that little image on the bottom left side of your workstation that shows you the 3D geometry and the relationship of all the vessels. If you actually segment out that entire geometry and use that entire geometry with some boundary conditions and some assumptions, you can actually glean information on hemodynamic significance that you would throw away. And that is the field, if you will, of CT-FFR. What CT-FFR capitalizes on is the ability to actually use the entire geometry and the relationships of the vessels amongst each other to actually use simulated stress and a computational fluid dynamics model to actually access the hemodynamic significant lesion. So that entire geometry is a huge part of the CT angiogram that's typically not used, but you're able to access a hemodynamically significant lesion. That's one side. The second part of the unused piece of information is in the contrast opacification itself. So it turns out that there is a relationship in a properly acquired scan of the way that the contrast changes along the lumen and the flow within the vessel. And you can mathematically show that relationship. And so typically you just give contrast, you enhance the vessel, and that's how you separate the lumen from a lesion. And that's what you see. However, if you take it one step farther and kind of use that quote unquote unused amount of information, you can then access either the difference in the contrast or the contrast opacification gradient, which is also called the tag, or you can combine that with other information to actually access more and more information about the hemodynamics of the blood vessels, or the coronary arteries in this case. It works for any vessel. You can do it in the mesentery, you can do it on other vessels as well.
And we, thinking about these tests, it's helpful to understand sort of their limitations. So we know that CT perfusion requires an additional CT image with stress, so an additional contrast load, and radiation. I think is a common feedback that is a limitation of that technique. With IVUS CT-FFR, the limitation may be the very long processing times, the assumptions based on your segmentation, which is a very particular process to do well. And then with CT gradients, though, with transluminal attenuation gradients, what do you see as the main limitation there, and how do you do that well?
Well, let me address some of the limitations that you meant. So the Core 320 radiation dose now is been accepted into AJRs coming out, and the doses are pretty reasonable. And so, yeah, it's a limitation of having radiation, but the CT, even the CTA dose plus the CTP dose plus all the doses from the planning scans is comparable to just the nuclear studies. So radiation, yeah, it's easy to play the radiation card, but radiation probably not so much a concern. CTFFR, sure, it has a long computational time and has a long segmentation time, and the segmentation is important. Computation time has traditionally always been very challenging at the beginning, and then it has gone down sequentially over the years. And so there's no reason to think that CTFFR cannot be done quickly. It might not be real time, like the reconstruction itself, but there's every reason to believe that that computation time will go down over time. Gradients has the nice advantage that it's the simplest thing whatsoever, right? It is instantaneous. There are software packages that do it, and all you're doing is measuring the attenuation along the coronary arteries. And it turns out many segmentation algorithms actually use the variation in the contrast to help automatically or semi-automatically do the segmentation. So it's not difficult to do. It's advantageous. The disadvantage that one might bring up is that while something like FFR is going to simulate stress, CT gradients, unless you're doing them on the stress images from a perfusion, are always going to be rest flow data. And so that incorporation of the stress piece has not, at least to date, been incorporated into the model. And so, there is no computational downside of doing the gradients. It's easy. It's simple. But it is rest data, and we've only done it on rest data to date. That's not to say that we can't do it on stress data and it won't show different things on stress data. It quite frankly should, because the contrast differences encode flow, right? That's really non-negotiable. That's the way the math works itself out. So as long as you can actually access the gradient and there's not so much motion from the stress data because the heart rate's so high and all those other things, if you can do that segmentation, you should be able to get that stress type of gradient out, but it hasn't been done yet. And that's really probably been the major limitation.
What about the scanning technique with TAG? We know, with helical versus a volume acquisition and the gradients you may get with helical.
Yeah, so that's definitely been an issue. Actually, in a recent editorial that came out with one of the Monash papers, the editorial clearly stated, I think Damini Day was the first author of the editorial, and I know Dan Berman was the senior author of that editorial. It clearly stated that it's very likely that gradients work on isotemporal data probably better than they do on helical data. I tried to make that very clear in the lecture and to show, the curves and how it's different if you have helical data over multiple heartbeats versus having isotemporal data. So there is an argument that you will, and physical reasons to believe that gradients will be better with isotemporal data. And so if you're going to do gradients with helical data, you're either going to have a much more complicated model. You're going to have to somehow compensate for the fact that your proximal coronary artery was imaged 3 seconds before your distal coronary artery. It matters because the contrast is flowing through, and modeling that flow is pretty complicated. And by that time, you might not want to actually do all that modeling. You've lost your benefit of the quick time and all the nice things about the gradients that, is the reason we invented them.
Dr. Rybicki, thanks for your time and for joining us today here at SCCT 2014 in San Diego. We'll be in Las Vegas next year, and we hope to see you there. For this and more videos, please check us out at youtube.com/firstinimaging. Thanks very much.
See you in Vegas, baby.